about managing snake bites, and because it's the Rattlesnake Festival, I'll focus on rattlesnakes, but really what I have to say applies to pretty much all pit biters. So I want to address some of the myths surrounding the treatment of snake bites, because there are a lot of them out there, and they range from just silly to outright dangerous, and I want to address those today. Talk about how we correctly manage patients in the hospital, and also what to do in the pre-hospital environments, because that's where you're going to get tested. So a little bit about me. So as a medical toxicologist, I deal with anything exogenous, anything foreign to the body that can poison you. So drug overdoses, adverse reactions to medications, occupational exposures, and all sorts of envenomations. Now, envenomations only account for about 10% of what I do, but they are by far my favorite 10%. I trained in emergency medicine like most medical toxicologists at Vanderbilt in Nashville, where this one was born. And we had a fair amount of vipers there, mostly copperheads and cottonmouths and the occasional timber rattlesnake. I spent a few years on active duty in Ohio and Iraq, and have a whole lot of envenomations there. Once in a while I get a bite. Then I went to Arizona, specifically to Bound Good Sam in Phoenix, to learn how to manage snake bites, because that hospital treats more snake bites than any other in the country, about 85 snake bites a year. And that's where I learned to do what I do. After Good Sam, I went to the University of Arizona, where I was the program director, and we had lots of snake bites, lots of Atrox, but also some speckled, some July, and some twin spot, a few other things. And now I'm in Texas Children's. Even louder? Okay. I can do that. Better? Alright. It's only got these things close to my face. Good. Alright. So, I don't treat a lot of rattlesnakes now because I work in Southeast Texas in Houston, but we do have rattlesnakes in the area. We have our pinky rattlesnake, we have our penguin, we have our western diamondback. Don't get a whole lot of those. I get a ton of copperhead and cottonmouths. In fact, I got my first bite in 2016 about 4 hours ago. Someone who's being treated right now for cottonmouth bites. So that's pretty exciting. Of course, in other parts of Texas, there are a lot of rattlesnake bites. We have some great snakes in this great state. These are beautiful rattlesnakes. We've got our mahogany, we have our blacktail, we have our prairie, we've got Massasauga, we've got rock rattlesnakes, and just a lot of great snakes. But unfortunately, sometimes you're on the wrong end of the snake-person interaction. And that's what we're talking about. So just to give an idea of how many bites are reported to poison centers around the country, this is from 2012 to 2014. And you can see that there are a lot of deaths. But there are a lot of people who have what's called major effects. And major effects we define as things that can result in a permanent disfigurement or a permanent disability or for life threat. So people need to realize that all pit vipers, whether they're copperheads, cottonmouths, or rattlesnakes, have the potential for serious badness. Now, interestingly, if you look at this, it suggests that cottonmouths are actually less dangerous than copperheads. That's not been my experience. And if you look at previous years, the cottonmouth data suggests that it was a little higher. But the last few years, we've had more bad outcomes for copperheads than cottonmouths. And I don't know why that is over the last few years. But certainly, rattlesnakes have the highest percentage of bad outcomes, because on average, they have the worst of the envenomations. So let's talk a little bit about victims. When you think about snake bite victims, there's two types. Legitimate victims are those who are sort of innocent. They're legitimately a victim. And, they're walking, and they're tagged, and they reach into a bush to grab a piece of equipment or something, and they get tagged by a snake. And not surprisingly, there's a fair amount involved feet. Almost half involved the feet. The others involve the hand. These people are innocent, if you will, although alcohol is still involved 60% of the time. This is in contradistinction to illegitimate bites. Illegitimate bites mean that someone is doing something stupid. And not surprisingly, it's almost always a drunk male. It's almost always a male. I remember when I was a fellow, I had a drunk female mistake bite. I was so excited because it was my first drunk female mistake bite. And almost all of them involve the hand, because it's an intentional interaction. Very, very, very few motion bites. But there is another body part that's affected besides the hand. What do you think that is? The mouth. Because people are trying to kiss the snake, or stick out their tongue at the snake. So there are some risk factors that you can use to estimate someone's likelihood of getting an illegitimate bite. And we refer to these as the T's of rattlesnake bites. You can see the testosterone, toothlessness, tattoos, etc. Now, some people use the tooth-to-tattoo ratio, and if you have a ratio less than 7, that's a big risk factor. And I should tell you, if you have a snake-related tattoo, it's a question of when you'll be envenomated, not if. Alright, so what happens? Have you already been tagged? Have you already been tagged? Oh, Dig's not over here. Alright, so what happens if you get bitten? Well, it's important to remember that a bite doesn't mean that you've been envenomated. Estimates are 20 to 25% of the time you're bitten by a rattlesnake, you're not envenomated. It's what we call a dry bite. In reality, it's probably a little bit lower, and some of those people who were alleged to have a dry bite probably just didn't show signs right away, and they were prematurely discharged. But it's still somewhere between 15 and 20% who don't get envenomated. There's a lot of reasons why that may be. Maybe the snake doesn't have any, or something preventing them from releasing venom time. I don't know. Now, if you are envenomated, how you respond to that bite depends on a lot of different factors, including the age and the size of the snake. Now, at this point, I want to tell you guys that this is going to be a interactive question. Okay? So get out your phones. I don't see what the computer. So get out your phones, and I want you to type Talks and text it to 22333, because this will allow you to anonymously answer questions. There's only about 3 of them, because we don't have all day. But this way you guys can participate in this. And this way, if you say something stupid, no one's going to know that it's stupid, except for you. So I'll give you all about 30 seconds to log in. Oh, you guys don't have your phones, that's right. Well, that's right, you don't have phones. My kids have been given me grief because they don't have phones yet. And my preteen daughter insists that she should have a phone. My son doesn't care too much. Alright, have you guys logged in? Have you gotten the message that you're logged in? Okay, so my first question for y'all, this takes about 4 seconds to load because I hate the ads. All I have to answer is A or B. What's more dangerous? Now, when I say big bite bird, just think rattlesnake, because these are slides from a generic lecture. What's more dangerous? Now, unfortunately, I don't have percentages here rather than total numbers, so I don't know how many people actually responded. So I'll give this 15, 20 seconds and see what people think. Okay, so this is what I typically see. The majority say that babies are more dangerous. Unfortunately, it's completely, absolutely untrue. It's actually the adult that's more dangerous. Now, the reason people think that babies are more dangerous are because of 2 myths in one. The first myth is that babies can't control how much venom they release. Years, but it's completely untrue, and it was disproved years ago at the Biology of Rattlesnake Symposium. Babies can control how much venom they release just as well as adults can. But even if that were true, but it isn't, even if it were true, 100% of a small amount of venom, say 2 milligrams, is a lot less than, say, 25% of 40 milligrams. So when it comes to snakes, and a few other things in life, let's try, yeah, you guys slides from this. Size matters. Just as clear. So, the larger the snake, in general, the more dangerous the envenomation, not the babies. Other things that determine how severe your envenomation will be depend on factors related to the snake and related to the patient, including their health and if they have comorbid conditions and where they got envenomated. Medical staff? That's how well they respond. But you're feeling better, obviously. Yeah, so how you end up doing it is absolutely related to medical staff. Yeah, so that's downstream. I'm saying the bite itself, there's a lot of factors that determine downstream. But yeah, absolutely. How you respond, how you ultimately do, depends a lot on the doctor taking care of you. And I will tell you, it's been my experience in Texas that a lot of doctors don't know what the heck they're doing when it comes to bites. And I know some of my friends here can attest to that. It's scary what's been done here. This is one of the eye-opening things when I moved here a few years ago. Okay, so if you are envenomated, regardless of how severe the inflammation is, we can break down the clinical effects into two types: the local tissue effects and systemic toxicity. With local tissue damage being way more common, over 90% of people have local tissue effects and nothing else. The systemic effects are a lot less common. Local effects can range from just a little bit of bruising around the site or a little fang mark all the way to frank tissue necrosis and loss of tissue. It's not common. I've treated about 600 snake bites, and I've probably had maybe 5-6 people lose fingers. I've had no deaths from snake bites and no permanent, well, I had one permanent long-term sequelae, something I had a stroke. But when it comes to local stuff, we've had a few fingers lost. And a certain amount of damage is determined the second the bite happens, regardless of what happens after. You're not great care, they just lost a finger. But it's still not common. Usually they get transient effects. All the pictures I'm showing, they end up doing fine with no permanent sequelae. So notice that this guy has a blister or a door. And notice he has a snake-related tattoo. So it was inevitable that he was going to get a snake bite. This is what happens when you try to kiss the snake. You end up with a tube through your nose, not your mouth. Anybody recognize the character? So we have a pet snake named Pliskin, and this is why. So in addition to the local effects, which are most common, you can have systemic effects. You can have what's called hematotoxicity, bleeding problems. That could be just abnormal labs or frank bleeding. You can have neurotoxicity. That can range from a little bit of weakness in your eye muscles to inability to breathe. You can have cardiovascular collapse or airway swelling. Even if you're not allergic, it can just be a bad one. Absolutely. I do talk about that a little bit. I'll talk about it in 2 slides. So, for hematotoxicity, sometimes they have no actual bleeding, nothing obvious, but their lab tests are all jacked up. They can have poor clotting function, where they have low platelet counts, where they have low fibrinogen. We did a study in Arizona looking at upper nosal bites, and you can see the percentage is not the same. More than half of people have coagulopathy defined by a prothrombin and about a third of them have low platelet counts. But most of these people had no symptoms, they just had abnormal labs. Sometimes they have bleeding, sometimes it's a little, sometimes it's a lot. And sometimes they actually have this phenomenon, it's really rare, they always ask about it on boards called DIC, where you consume all your products and you actually get clots as a result of getting things like stroke. That's really, really rare, but it can happen. Neurotoxicity is typically seen in just a few species of rattlesnakes. The most famous one is the Mojave. This is a picture of a Mojave taken on State Route 51 in Phoenix. But there are other species that are associated with neurotoxicity. The Southern Pacific, for example, certain diamondbacks and certain Western kangaroos, but they're not as common as the Mojave in the Southern Pacific. And it can range from eye muscle weakness to inability to move your arms and legs to inability to breathe. And it's because they have different components in the anatomy. And then like I said, cardiovascular collapse, anaphylaxis, previously sensitized, they can have muscle breakdown, even if they don't have high blood pressure, which can be a direct effect on the muscles. So what do we do about this? Well, I want to talk about pre-hospital screenings and then what we do about snake bites in the hospital. So I want to give you the word on pre-hospital, and that word is avoid. Because almost anything that's been proposed in the past, you should avoid. First, avoid getting bitten. Now, this doesn't apply to the patient because he or she's already been envenomated. This applies to you, the person administering the care. You should avoid getting bitten in the process of caring for other people. And the best way to do this is by not going after the snake. There's this myth that you need to identify the snake in order to determine how to treat it. And that's not true at all. Whether it's a copperhead, a cottonmouth, or a rattlesnake, the treatment is exactly the same. It's a pig bite for envenomation or it's not. And that's a clinical diagnosis. We as physicians do not need to know the species to know how to treat them. Now, last year at Texas Children's with Tom, we were doing a study specifically on copperheads. So I needed to know the species if the person was over age 12 and hadn't gotten treated, and hadn't been drinking, and all that sort of thing. But that was just for my study, which we'll talk about later. Other than that, we don't need to know the species. So you don't need to know the species. You don't need a picture. You don't have to go out. If you can safely get a picture of the snake, awesome. Please don't kill the snake. If you bring a snake in live, I'm okay with that, although my staff hates that.
Just to clarify, that's for a pit viper, not any subtropical or
Well, here in the United States, we don't use the species because it's either a pit viper bite or it's not a pit viper bite. That's all we need to know. So, don't get bitten in the process of caring for something. Don't cut and suck. This is the process where you take a knife, make an incision, and then you start sucking up the venom. Now, I would have thought that most people know this, and I shouldn't even have to mention this, but you know what? Not only did this happen last year, this was reported as a good thing, and people were commenting on an article how she saved her son's life. This is the stupidest thing you could possibly do. This does absolutely nothing to help with bites. And you're making a wound worse by cutting into it, and now you're introducing bacteria from your mouth into a wound. This is not helpful at all. And theoretically, if the woman doing this had a lesion in her mouth, she could theoretically get a small amount of venom in her blood. Do not cut and suck. We should not do electric shock. This, too, is something I would think people know, but people try this. Now, I'll admit, it's fun to shock your friends. It's like a Tarantino film. But it does nothing to actually help the bites. It does not help. It may cause burns and hyperpigmentation, and even death. So, electrotherapy is great for torture, not great for snake bites. I'm not advocating torture, by the way. I'm just saying it is effective. Avoid ice. Now, this is a controversial one. Needlessly controversial one. People who've been tagged tell me they feel better when they put ice on their bites. In fact, the snake bite I was thinking here today came with an ice bite. But here's the thing. In one study, it showed no improvement. Although, again, people say they feel better, that's sort of improvement. But in the second study, it showed that people who got ice or other cryotherapy actually did worse. And it makes sense, because you're cutting off the blood supply to the affected area. So they're more likely to have permanent tissue damage. So it may feel better in the short term, but if it's costing you tissue in the long term, don't do it. Avoid a tourniquet. Now, if you're bleeding to death from an extremity wound, yeah, we use a tourniquet. But if you get bit by a snake, cutting off the blood supply to that extremity is not helpful. Even pressure mobilization, where you use either, a band to control the flow of the lymph, or if you wrap it with lace bandage, we also don't do this because what we see with pit viper bites, whether it's rattlesnake, copperhead, cottonmouth, is local tissue damage. And anything that's going to keep the venom in that extremity causes worse damage. In fact, this has been studied really well in North American pit vipers, and we know that we do not do pressure mobilization. Now, for a coral snake bite, this is really helpful. But for pit vipers, for rattlesnakes, absolutely not. They do worse when you do pressure mobilization. What about venom extraction? Now, this is different from the mom putting suction on a wound. What about the commercially available venom extraction devices? Well, avoid those two. The theory is great, but they don't actually work. I'm sure a lot of you know who Sean Bush is. He used to be at Lowell, now he's in East Carolina. He just hosted the most recent Venom conference, Venom Week, and he wrote, if not the best editorial ever, certainly the best title editorial ever, back in February 2004. He looked at all the literature on extraction devices and came to this conclusion. Turns out, they don't remove venom, they remove interstitial fluid. So what you're doing is concentrating venom and causing more tissue damage. So do not use extraction devices, they don't help. So what should we do? Don't get bitten, support the airway bleeding circulation, give them pain medicine if you have it, if you have to have your oxycontin, shoot with some heroin, shed it. Get them to the hospital quickly but gently, and then position the affected extremity correctly. Now, before you answer the question I'm going to ask, think about what I told you about, what we see with pit viper bites, and what we try to avoid. For pit viper bites, do you want to elevate or keep it below heart level? So at least one person's lights out. So remember what I said. we see almost exclusively local tissue damage. And everything here was directed toward minimizing the local tissue damage. So when you have a bite to the extremity or a pit viper, you want to elevate. You want to reduce the hydrostatic pressures, prevent anything from accumulating in the extremity, prevent any swelling, because that can cause increased tissue damage. So we always elevate. The second you get tagged by a pit viper, get your arm up, unless it's your leg. You can get it up right away. Remove any restricted clothing, get it up, and keep it elevated the entire time. Anyone who tells you anything differently is innocent. In fact, it's one of the first things people ask about. You know, I belong to the North American Snake Bite Registry. One of the first things they ask about is the elevated extremity. And if you look at this unified algorithm, which we'll talk about later, the very first thing is identify how much is spread. The second thing is elevate the extremity and organs. Get it up to reduce the local tissue damage. So in the hospital, we're going to address any life risks. If they have problems breathing, if they have problems with their blood pressure, we're going to get the pain under control. We'll consider the need for antibiotics, and of course, we're going to avoid unnecessary stuff. So, addressing life risks, we're going to give a life-saving tetanus booster. Now, in case you're wondering, there's no report of anyone ever getting tetanus from a pit viper bite. But there are people who've gotten tetanus from viper bites in Africa, probably just their conditions. But anyway, if your tetanus is out of date, we'll update the coverage. We're going to assess the local tissue damage, and there's different ways of doing it. Sometimes they'll draw a line, you know, and then another line as it starts spreading. Sometimes they start drawing a line in all different directions, and as somebody who does this professionally, it makes me crazy because it's like reading a supplement. Honestly, what I just do is I measure the circumference of different areas and see how they change over time. That's all I care about. Somehow they're going to have to assess the progression of the local damage. You have to watch them for a while. And one of the most common mistakes I see when it comes to pit viper bites is premature discharge. Either because they're in a rush to get patients out or they don't know any better. Sometimes they'll watch someone for like 2 or 3 hours and then send them home. For an upper extremity bite, it may take up to 8 hours to show toxicity or progression. For a lower extremity bite, it may take 12, 18, 24 hours. So at the minimum, we want to take 12 hours. And again, any systemic toxicity, they have to be observed over minutes. So you've got to watch them to see what happens. There are certain lab tests, we need certain lab tests we can consider getting. These may not mean anything to you, that's fine. Just know that they're doing something else. I just want to show you a picture. You may or may not get X-rays. When you were tagged, did you get X-rays? Yeah, it's not a big deal. I was like, like I said, I've treated about 600 snake bites. I've probably gotten 1 X-ray in my entire career. They don't really change the management, but some people want them fine. You want to give them pain medicine, but there's certain things you want to do and certain things you want to avoid. Ibuprofen is a great pain medicine, but not for snake bites, because its theoretical effects are illegal. And Tylenol is a good one, but sometimes insufficient for the pain. So we want to use both units. But we don't typically use morphine, which is the most common IV pain medicine, because it releases histamine and theoretically that can increase the swelling. So we use other pain medicines like Dilaudid and Phenyl. And of course, to help the anesthesia, we want to position so put the arm up, get the leg up. So if it's a little kid with a low extremity bite, I hook up this traction splinting, and it looks crazy, it looks like they have a femur fracture, but they feel better right away. For older kids who can pay attention to instructions, I'll just prop them up against the pillow. The leg is straight, pulling the foot elevated, so then he's like a 45 degree angle. Now let's talk about anti, or is it anti-venom? You'll hear people say both, but half the people are wrong. Because the World Health Organization in 1981 said that in English-speaking countries, the correct terminology is anti-venom. So it's only okay to call it anti-venom if you're French or ignorant or arrogant, which is the same as French. So if you're French or ignorant, then it's anti-venom. Otherwise, it's anti-venom. And well, the old stuff, yes, is as you see in about 5 seconds. What we use now is not the case. So, currently, there's one FDA-approved and available antivenom for all U.S. pit vipers, and that's Conroe. And this is totality monovalent unicat ovine. It is sheep-derived. The stuff we used to use, the Wyeth product, came from a horse. It was very effective and very unpleasant to experience. But what we have now is Conroe. It was the only one to go. Now, there's another antivenom that was FDA approved last year, but it's not commercially available and won't be for the next 2 years or so. And that is, of course, the right. So how is ProFab made? So they find some sheep volunteers whose families get paid handsomely, and they hyper-immunize the sheep with the venom from 4 different pit vipers: the western diamondback rattlesnake, the eastern diamondback rattlesnake, the Mojave rattlesnake, and the cottonmouth. So they immunize the sheep with these venoms, and then they collect the antibodies. Then, knowing that the reason the older antivenoms have such a high allergic reaction is because this portion down the bottom here, they get rid of that using papain. So before we treat anyone with ProFab, we have to ask them 2 questions. 1, are they allergic to sheep? And 2, are they allergic to papaya? I'd say for every 3rd or 4th patient I ask if they're allergic to sheep or papaya, they think I'm playing a joke, and I'm like, no, I need to know, are you allergic to sheep or papaya? I've never had anyone be allergic to papaya, although I've had a few people say it's disgusting. They're wrong, but I treat them anyway. Papaya is awesome. But you have to know that before you treat it. If you had high ability with papaya. Yeah, or wool. So, but mostly, if they've been around sheep a lot. Alright, so, when do we use ProFab? The indications are if they have progressive local findings, or if they have any evidence of systemic toxicity, the hematotoxicity, the neurotoxicity, or any of these bizarre anaphylaxis and other things. And the way we use it, most of us follow this unified algorithm. Now, the manufacturer says use 4 to 6 vials initially. Certainly, for someone who's much sicker, you can use much more, and I've started with 8, 10, even 12. But what I won't do is give an odd number. So, 4 to 6, no, 2 to 4 or 6. Now, you may think it's because I'm superstitious, and I am superstitious, but that's not why. It's because it comes in a box of 2, and invariably, if you open the box and you only use one, the other one gets lost, and that's a waste of resources. So if you open the box, just use both bottles. So you give 4 to 6 initially, like the kid I'm treating right now just got 6 vials, and then you determine if you have what's called control, meaning there's no progression of local findings, and the labs, if they were abnormal, have improved, and inadequate to do it. So, if you've got the control, then we start on what's called maintenance dosing, which is an additional 2 vials every 6 hours for 3 doses. If you have not taken control, we give them another 4 to 6, and we keep doing this until we've gotten control. So, in a perfect world, and honestly most of the time, you have a bike that looks like this on, say, Sunday, so this kid actually got tagged on a Saturday night. Mom suspected it was a snake bite. They were at a state park. And so the EMT said, oh no, that's a thorn. He came in on Sunday, after the people, she said, well, I think that's an infection, not a snake bite. We should get checked out right away. He came in on Sunday, he got anti-venom elevation, and on Tuesday, that's a mistake. Because when you treat them correctly, they get better. Now, sometimes people decline anti-venom, or doctors refuse to use it because of various reasons, and one of them is the question of safety. So I have a question for you. Will this or will this not work? That's my question. How often do you have an acute allergic reaction following COVID? Is it 5 to 10% of the time? To 100% of the time? Or somewhere in between? What do you think? How often do you get an allergic reaction following COVID? I think we know who's going to win this guy. And that is correct. So about 5 to 7% of the time. So in 2011, Tim Schiff and some other folks I know did a study, a meta-analysis of multiple studies looking at the acute allergic reaction incidence. And they reported an incidence of 8%. And I know it's actually lower in real life because some of the patients who were in the study didn't really have allergic reactions. I know that because some of them were my patients. Anybody who got Benadryl was considered to have an allergic reaction, even when we gave Benadryl to some kids just to make them sleep at night. So they quoted an incidence of 8%, and 50% of service cases, which is the waiting time, hypersensitivity. I can tell you, I've treated about 500 patients, and until today, I've only had 3 people have allergic reactions. I had a 4th one today, it's very frustrating. And in a more recent study, looking at ProFab compared to the other ones, it was an incidence of 2.75%. So it's actually very safe with a really low incidence of allergic reaction. Now, some people, what's that? No, we don't just use that. it's not a good predictor of who's going to have an allergic reaction. So yeah, we can't test for it. Now, I've heard people say, oh, well, once I get the anti-venom, I can't get it again. Well, you can imagine, many people who've been tagged by snakes get tagged again because they play with snakes, they're going to get tagged. I've treated almost 2,000 people with multiple, ranging from 2 to 6 to 7 snake bites. And I've never had anyone have an allergic reaction in a subsequent encounter. Now, the best patient I believe I was this guy, who was always trying to hurt himself through a variety of methods, including snake bites. He's been treated with Profab 19 times. He's also had bites from other snakes that don't respond to it. And of the 19 times he's been treated with Profab, he had 2 allergic reactions that were mild, and 17 times he been fine. So you can definitely, and most of them including the patients, know that he previously had an allergic reaction. So you can definitely get Profab again, and in this case again and again and again and again. So the last thing is when you come into the hospital with a snake bite, it's really important to avoid unnecessary and or dangerous interventions, such as antibiotics. When I first got here, it seemed like the approach to snake bites in Texas was antibiotics and surgery and steroids. Well, prophylactic antibiotics don't really work. They don't prevent anything. Most people with snake bites don't get infections. They have antimicrobial properties from the venom, so you don't really see infections. We did a study that was presented in Clearwater, Florida last year. There was one person out of, I don't know, 100-something who had an infection, and that's because she kept chewing on her bite the entire time she was in the hospital, so she would get used to the infection. In general, antibiotics are completely unnecessary for snake bites. So are steroids. In the past, it was a common way to treat them. Steroids are only necessary if someone has an allergic reaction, which again is really rare. And surgery, they don't need that either. So, I like this paper because it was written by toxicologists and surgeons. The lead author is a trauma surgeon in North Carolina. And they looked at different indications for different types of surgery for different types of situations. And certainly, cutting out tissue after a bite has been shown to be harmful, not helpful. But incision isn't what we think about in surgery. We think about fasciotomies, and I'm sure there's like 3 dozen people in the audience, or in this entire room, who've had fasciotomies for snake bites. Certainly, prophylactic fasciotomies don't help. They cause cosmetic problems, functional problems, and they don't help. And we know in animal models that fasciotomies actually make things worse. Look at that. 4.5% of people, animals, had myonecrosis. The muscle died when they got fasciotomy, which is 2.5 that didn't. In this study, this is a rabbit study, if they just got antivenom, they survived all the time. If they got antivenom plus surgery, most of them survived. If they got nothing, only 30% survived. If they got surgery, only 30% survived. Surgery does not help. But what I think is most interesting is, even when someone has evidence of compartment syndrome, when they have high pressures, which is the rationale for doing fasciotomies to reduce the pressures, even if they have compartment pressure, fasciotomy does not help. It doesn't help. And the reason for that is because when you have high compartment pressures from a snake bite, it's different from, say, having high compartment pressures from trauma. It's not a cause of the problem, it's a sign of the problem. It's a sign of an envenomation. And the way we treat envenomation is with antivenom. So really, there's no benefit from surgery. If they have bad envenomation from the antivenom, and even the surgeons recognize this. Antivenom is safe and available. Surgery is only reserved for people who fail to respond to antivenom. They know people respond to antivenom, so they don't need surgery. So what do I want to do with this? Number one, pit vipers, including rattlesnakes, are primarily local tissue damage with rare systemic toxicity. Most things you can do in the hospital are dangerous and useless. Just get into a hospital safely in the position of antivenom for aggressive local farming or systemic toxicity. Antivenom is generally safe and effective. And you don't need, you can get it one once, and you don't need surgery. Now, before I take the question, I want to tell you about the fourth annual Houston Venom Conference, May 18th this year. It's designed for medical personnel, but there's a lot of lectures there that will appeal to people who are interested in snakes and other innovations, even if they have no medical background. It's a fun event. I think it's $10 just to pay for the food. And if you're an EMS provider or a physician, we actually offer CME and CE for free. And it's just fun. It's at the zoo, and they all college of medicine. Bless you. Millions at the zoo. And with that, I'm happy to answer any questions you may have about snake bites. Bless you. Yes. Yeah, in the box is $2. So, you know, how much a hospital charges for that varies from hospital to hospital. But typically, it's going to cost the hospital $2,500 per body. So if you get 10 vials, you know, it's going to cost the hospital $25,000. And you know, some people say, oh, well, that's a lot of money. But you know, how much does a permanent disability cost in the long term? I know I would never hesitate to use program myself or a loved one because you're going to be better. Anything else you guys need? Yes. Yeah, so some hospitals don't want to deal with sick place and they'll just transfer out. And honestly, hospitals that don't deal with sick place regularly probably shouldn't deal with sick place because they do it very poorly. I always think they should come, honestly, I think they should come to me. But if they can't come to me, they should come to some state by experts. That being said, sometimes hospitals run out and they don't have a handle, so they skip. I've actually completed Texas Children's of antivenom once or twice before I sort of insisted they keep 18 vials on hand at all times because I had 2 bites coming in the same day. So luckily the Texas Clinic Center, you can't sort of get a path that in the hospital. So we just got into the in the hospital. Zero. Why would I call that a zero?
Well, no.
Yeah, but we have tons of antivenom in town. And the zoos have exotic antivenom. So I know they like to build themselves the Mecca, the United States. There's no need whatsoever to call anyone outside of Texas. Anything else?
Self-injection.
Self-injection? That's insane. And in fact, there was a herpetologist who thought he could build up immunity, and in subsequent bites, he didn't have any effects. It turned out he kept getting bit in the same place in the open house. Once he actually got exposed to venom, he almost died. So no, you're not successful in your video therapy.